I want you to listen to something, what is unfortunately a very common problem.
My name is Carlene. My husband and I, we've gone without a family doctor for about 2 years.
My name is Allie Ballin, and I've been looking for a family doctor for about 4 years, since 2019.
I got so desperate at one point, I called every physician that practices in our city. I am visually impaired. I am not able to drive. Taking the bus to another city when I'm not feeling well is not really appropriate nor great for me.
Every office that I've called to inquire about has put me on a wait list. I have not moved up on any of the offices.
Now, according to a recent Angus Reid survey, close to 20%, so 1 in 5 Canadians, do not have a family doctor. So, where do they go when they need medical attention, right? Well, the way I see it, they have 3 main options. 1, go to a walk-in clinic. 2, go to a hospital. Or 3, go it alone. Now, for almost my entire adult life, so from Montreal to Vancouver to Toronto, I've fallen into that first category. So I basically see whichever doctor will see me at whatever clinic is open, because finding a family doctor is just hard, right? We just heard it. But today we're going to do 2 things. We're going to hear from a family doctor about why it's well worth the trouble to find one, and maybe for reasons that you haven't thought of. But we're also going to take a closer look at a truly comprehensive healthcare solution that has been in development in this country for nearly 20 years, but that most Canadians don't have access to. And that until recently, I'm embarrassed to say, I never even heard of. But first, we have invited Dr. Danielle Martin, family physician, to join us here in studio to help walk us through kind of what we're missing when we don't have access to this pretty fundamental continuum, right, of care, primary care. And first of all, how are you doing?
I'm great. Nice to see you.
Yeah, thanks for being here. So full disclosure, okay, so let me set this up this way. I'm a walk-in clinic guy, okay? So I'm sorry. I know that hurts. But it's actually kind of worked out okay for me, right? I get my prescriptions filled just fine. I have asthma, eczema, whatever. I can get EpiPens when I need them. I've got a little bit of a rickety shoulder, but and maybe some crackly knees, but that's just because I'm getting old, right? So it's not that big of a deal. Tell me, what am I missing?
Yeah. I mean, first of all, what you're expressing is that you value the convenience of the walk-in clinic.
Yeah.
And I agree that you're entitled to that convenience, and that we need to try to build models of family medicine and primary care that respect your time and where you can access what you need easily. But a walk-in clinic doctor is not going to have time or relationship with you over time.
But they have
to
my
notice,
records, right?
No, they really don't, and they're not shared. If they have them, it's not their obligation. They're treating every interaction, that's a walk-in clinic, as a one-off interaction. They are not taking responsibility for your ongoing care. So they're not going to step back and say, did you know, Andrew, that actually asthma and eczema are linked? And that actually that puts your kids at risk of certain kinds of other allergy related issues over time, or that actually maybe that rickety shoulder and that rash are linked and perhaps it's not eczema. Your family doctor knows you. They don't specialize in a disease or an illness or an organ or a body part. They specialize in their relationship with you. And they will notice that your blood pressure is creeping up. They will help you to prevent yourself from getting sick by doing the regular monitoring for chronic diseases. Have we checked your cholesterol? Are we keeping an eye on your blood pressure? What was your family history again? What did your mom have? Do we need to screen you early for certain forms of cancer? And recognize the interplay over time and space of what is happening in your life, what's happening in your body, what's happening in the community around you that affects your health. That's our job.
It sounds like what you're saying is that family doctors are not only exceptionally good at noticing things, but noticing patterns, I guess,
Patterns
too,
is what
right?
it's about, and the specialty really is about relationships. So if I've never met you before, I might not say, you put on a bit of weight or whatever, I think it's noticing change over time. So patterns in the individual, as well as patterns of symptoms and at the level of the population. But I might also say, I'm wondering if there's a link to what you're eating here. Maybe we should get you connected with a dietitian, or every time you come in here with an exacerbation, it's because you're under mental stress. It's time for us to connect you with a therapist. So it's not just referrals to medical specialists, it's the full range of healthcare providers out there.
I normally think of doctors referring people to other doctors, right? To other specialists.
But we refer to social workers, to psychologists, to pharmacists, to dietitians, to to physiotherapists and occupational therapists. So, helping to determine who is the right professional, the right healthcare provider to support you is a big part of what we do in family medicine.
So why is it so damn hard to find a family doctor?
It's so hard, I know, and it's such a tough problem. I mean, some of it is because our population in Canada is growing, but it's also aging, which means the family docs are aging. And so retiring. So we've seen, then add the pandemic to that. So we've seen a doubling of retirements during the pandemic here in Ontario.
But those doctors aren't being replaced.
It's impossible to replace them at a fast enough pace.
And that's not an exaggeration, by the way. At the outset of the pandemic, during a 6 or 7 month period, we saw 385 doctors stop practicing. This is according to a recent study in the Annals of Family Medicine. And that number is about double the number of doctors that we typically see retire during that same period of time every year between 2010 and 2019. That's 170,000 people who just lost their GP.
And part of that is also because the practice has shifted. The new generation want to work in a much more supportive environment. They want to work in teams. And a team means multiple doctors working together, but it also means multiple doctors working together with nurses and pharmacists and social workers and all of those other healthcare providers.
So all of these doctors under one roof?
Sometimes under one roof. Sometimes it's more of a, we're in the same neighborhood and we share calls. So I'm allowed to take a vacation, but somebody's got to take care of you while I'm away.
Right.
My colleague steps in. So it's about cross coverage, and it's about all of these other kinds of providers, so that I have an elder who's taking 8 medications and now they've got COVID, and I got to put them on Paxlovid, which is a medication that has 1 million drug interactions. Rather than spending my whole afternoon trying to figure out what to do, I pass that person to the pharmacist. And the pharmacist knows how to figure out what to hold, what to discontinue, how to adjust doses of things, get them on the Paxlovid, help me with the prescription, and I can move on and see the next person. So it's teams, and we haven't been building the teams for our new grads to come into. So people aren't choosing family medicine.
Right, and yet, and I just want this to be clear for folks who are listening to you talk about this sort of team-based approach. This isn't just like an idea that someone has.
No, this is a thing. About a third of Ontarians have access to a team right now, either through a community health center or a family health team, and that's just in Ontario. Those numbers are lower in some other provinces and territories.
And yet here I am, in not just in Ontario, but in the biggest, most populous city in the country, not able to find a single family doctor, never mind the team-based approach that you're talking about.
So we're going to have to, we don't bat an eyelash when we have to spend $1 billion to build a bunch of new hospitals, fancy buildings. We are going to have to invest in primary care in this country. We know that health systems that are built on a strong foundation of primary care have better health outcomes for patients, better equity, and lower costs. You don't end up in the hospital with a stroke if your family doctor has been seeing you and managing your blood pressure. You don't end up with a late-stage cancer if you've been getting your regular screening. So primary care more than pays for itself. But we just keep investing in the fix-it shop, which is the hospital, and under-investing in the community. So I'm not talking about paying family doctors more for their individual work. I'm talking about building those teams and infrastructure that make it attractive for new graduates to choose family medicine and to provide this kind of care. Because you're right, otherwise we end up in a situation where people use walk-in clinics, and it can be convenient and fine when you're young and healthy, but every investment of a visit that you make with a person who knows you will pay you dividends later when you need healthcare, which, if we're lucky enough to live long enough, we're all going to need.
Dr. Martin, thank you so much.
Thank you.
We have a lot to talk about on the other side of the break. More on this team-based approach in just a moment. Okay, so I'm here outside the Parkdale Queen West Community Health Center, exactly the kind of place that Dr. Martin was talking about just before the commercial break, because we figured the best way for me to learn more about what goes on inside is to actually just go inside, and I know my producer Drew has something that he's cooked up once I get in. Okay, let's go.
Right.
So what are we doing here?
We're going to take you on a patient journey at this health team.
Mic'd up, you can hear me? 1, 2, 1, 2. All good? So this is a reimagining of who I am today.
That's right.
In a way. Okay,
That's
I got
right.
it. Okay, let's head on down.
Yeah.
Thank you, Drew.
Yep.
Hello?
Come on in, Andrew.
Hey, Angela.
Hello.
Can you tell me about this place where we're at?
So this is a community health centre, Parkdale Queen West Community Health Centre, and we are one of over 70 community health centres across Ontario. In addition to the physicians, we have nurses, nurse practitioners, which are the advanced practice nurses, and we have physiotherapists, we have social workers, high need populations, so therefore you have complex health conditions that people have that is also complicated by social determinants, poverty issues.
I have a feeling that there are some complex conditions in this
there
envelope.
is.
Is this a good time to open? Should I open this?
Do.
Okay, so I'll just read this out loud. You are a 50-year-old man. You live on social assistance because you sustained an injury at work 10 years ago and haven't been able to work since. Recently, you started to experience frequent urination and you're losing more weight than usual. You live alone and don't eat as healthy as you know you should. Mm-hmm. If I walked into this health center with this series of medical issues, what happens?
So what would happen is the first person who you would come up on likely and be directed to would be our intake worker, which would be someone who would take, the details, and then they will use that to then connect you to the right care provider.
And who is the right care provider
The
in this
first
case?
right care provider, given what you have there as your condition, would be a nurse practitioner and or a physician.
Can we go?
So we can definitely take you to the nurse practitioner.
Hi there.
Hi,
Shona.
Andrew. I'm Shona. Yeah.
Nice to meet you. So I'm coming in here with a whole host of issues that I'm struggling with. And maybe the most acute one would be this frequent urination. So I have to pee a lot more than I used to and losing weight. Does that trigger alarm bells?
Absolutely. One of the things that we worry about when someone would come in with peeing a lot, losing weight, first thing you think of is diabetes.
And so what would you do in that case?
So I would take a bit more of a history. I'd work out if they had any other symptoms. I would order some blood work because we can diagnose from a really simple blood test. Doesn't even have to be fasting. We can even do that here. I would connect you to our diabetes team. So diabetes nurse educator and dietitian who would work with you around learning about diabetes, any sort of lifestyle measures that you could take. And
Can we have them come
She's
in?
actually here today, so I can go and bring her in. Her name is Jane.
Wonderful. Okay, I'll wait here.
Thanks very much.
Okay, so just as I wait for Jane, the registered nurse and diabetes educator, to arrive here, I'm struck by something that Shona mentioned as she was leaving. And she was saying that this case study that I've got here, being a 50-year-old man on social assistance, frequent urination, losing weight, not eating as healthily as I perhaps should, she said that this is actually a remarkably straightforward case for them, that usually they handle much more complex cases, sometimes involving things like substance abuse or mental health illnesses. So this is something that they seem pretty well equipped to handle here. Hi, Jane. How are you?
Nice to meet you.
Nice to meet you too. You're a diabetes educator.
Yes.
What is it that you and I would be having a conversation about at this point, after I've done some blood work and I've sort of confirmed the worst?
A lot of it is talking about what their treatment is going to be. So if they don't want to go on the route of starting any medications, then we look at lifestyle for at least 3 months. And if the lifestyle alone hasn't, we keep it in the back of our minds that, we may have to add some things to your treatment.
What might be a logical next step from there?
Is a case manager.
Okay.
Yeah, a case manager would be helpful for you in your particular case because you've been unemployed for a while, you live alone, you're on social assistance, so those are all the social determinants of health that can impact how you manage your diabetes.
Can you introduce me to that person?
Absolutely.
Okay, let's go.
So let's go.
Ah, perfect.
Tandy. How are you?
Hi, Tandy. I'm Andrew.
Hi, Andrew.
Nice to meet you. Thank you so much. I appreciate it. What goes through your mind as you see those?
Somebody that needs a lot of support to get to a place where they're healthy and they're empowered around their health. So I see things around food insecurity.
Right.
So if you're not having adequate food, how can you stay healthy?
How would you help me on that front?
Oh, I would introduce you to one of the team on the first floor that would help you with food resources, food banks. Sometimes we get donations of fresh food.
I mean, medically, I suspect at some point I would actually need to sit with a medical doctor.
Yep. So then you would also be referred to Dr. Gillis, who's one of our physicians here.
Can you introduce me to Dr. Gillis?
Absolutely, I'd love to.
Okay, let's go.
Let's go.
Hi, it's nice to meet you. I'm Alison Gillies.
Okay, so this has been a whirlwind so far. So after I've had a conversation with someone like Tandy, a casework manager, what would our conversation be like?
So in the case that's being discussed today, so for example, someone coming in with new diabetes, I'd be wanting to, get a sense of what the symptoms are, making sure that we're doing a physical exam, checking the blood pressure, seeing if there's any nerve damage from the sugars having been high. There's screening that needs to be done, eye screening, for example, because the high blood sugars can cause damage to the eyes. Right. So it would be coordinating those tests and then arranging follow-up based on the results of those findings. So if everything is going really well and things are well controlled, I might be seeing you again in 3 months. If the results are coming back in a level that is more concerning, I might be seeing you again in 2 weeks.
Dr. Gillies, thank you so much for this.
You're welcome.
I appreciate it. Angela, this place is incredible.
Thank you.
I'm struck by just the diversity of expertise in this building. It seems to me like you're really looking at the whole person.
The whole person.
And how closely are all of the professionals in this building working with each other? Are they consulting each other often when they share patients?
Yes. So we are all part of the circle of care. So it means that if you see a physician, then that physician can easily chart something in the clinical record, in the client record, and the social worker can pick up on that to follow through with what is being requested on the part of the clinical team.
What kind of financial pressures are there on you to churn through patients as quickly as possible? I'm looking at this place and I'm trying to think, is this more like a shopping mall or an assembly line?
I would say that it is a lovely food court. In that you have a range of offerings in a single setting, and that you are directed to the stations which best meet your needs. In terms of resourcing and the churning, is because we're in a salaried model, it means then if you need some more time, then the provider can spend more time with you without it becoming an impact on billing.
There's no 1 or 2 issues per visit.
No.
Here, right? There's no requirement to just push people through as quickly as possible.
Yes.
If someone has 6, 8 issues,
then we have the ability to deal with 6 or 8, but it also means that the pressure isn't on one single provider to respond to the 6 or 8 needs. That single provider may have 4 other people that they can draw on to support and again encircle the client.
Because otherwise, if such a person did not have access to a place such as this, how would they manage?
Well, I think in the absence of team-based care, then an individual who is marginalized, who is already facing challenges, and or even, your person who is relatively settled and stable, can spend a lot of time, what I call hopscotching, within a system to find the care. And particularly for folks who may be in a workplace where they don't get time off to go to a myriad of appointments, then being in a space where you can be attached to multiple services,
it's a lot easier
sometimes in a single visit,
just to come to one place.
It's easier. It is easier.
So Angela, why isn't there one of these places on every
street corner in every neighborhood in every province across this country?
Well, you know, you're saying what is my desire. You're saying what is my desire, and I would say that these kinds of integrated care services can sometimes be seen as by the system as an expensive model.
Right.
And I think when you look at the expense that you'd spend in building this kind of team-based care versus the expense that you will spend in an acute setting responding to what happens in the absence of this kind of team-based care, is you'll spend more. You'll spend more in the acute care responding to the emergencies created by the absence of team-based care.
Right.
And that's a high-ticket item. And I'm saying, no, more beds might be needed. What we have may be imperfect, but certainly more weighted investment should be placed at the genesis of the site of need, which is in community and team-based care, and bringing care also closer to where people are.
Angela, you've been exceedingly generous with your time, your expertise, and your team. Thank you so much.
Thank you deeply. Thank you. Thank you.
Hey, welcome back to About That. So hey, that was like genuinely cool to be there at the Parkdale Queen West Community Health Center. Big props to Angela and company for showing us around. Thank you for that. And you know, this is something that exists in other places too. There are apparently dozens of such community health centers in Ontario, although about a quarter of Ontarians have access to a community health center. And you know, I just think of myself. I mean, in my case, I've been on this planet for nearly 4 decades, and I have never encountered this sort of thing until starting to do this story. And I've lived in 4 major cities, right? Ottawa, Montreal, Vancouver, and Toronto. Although what I'm told is that for these particular types of community health centers, they do tend to be more prevalent in rural areas than you might find in urban areas, this kind of team-based care. But hey, it's interesting, right? And if what Danielle Martin said was true, that there is a problem in trying to refill all of those positions in general medicine and family medicine that were vacated during the pandemic, interesting to think that maybe this provides sort of an attractive workspace for folks to get into this type of medicine.